Can we help? That's not us. Hello. Who is going to help us? This is a complexity of epidemiology and interactions. All right, morning everyone. I'm Olumiwo Dusonya. I'm from Lagos, Nigeria. I'm an epidemiologist. Presently, I serve as Vice Chancellor of the Lagos State University of Science and Technology in Lagos. On behalf of myself and Professor Peter Nyasulu, who is from Stellenbosch here, we welcome you to this session where we're dealing with emerging issues in epidemiology. We'll have two sessions of presentations this morning. The first five speakers are here, and they will be speaking on a number of topics from Lillian to Ntokozo to Santos to Drea and Kendra. Very interesting topics, and I want you to please participate, listen carefully. They will speak for 8 minutes. Please keep your questions and comments. We'll take all of them after the first roughly 40 minutes, and then we'll have the second 5. So I welcome us, and we are ready to start. So I'll call up the first speaker. We'll be talking to us about early life factors with childhood trajectories of violence among the birth to 20 plus cohort in Soweto, South Africa. Welcome this morning, Lillian Mukai. Please welcome her.
Thank you so much. Morning, everyone. My name is Lillian Muchai from the University of Witwatersrand, and I'll be presenting on my project that looked at early life factors associated with childhood trajectories of violence among the birth to 20 plus cohort in Soweto, South Africa. Now, violence against children has long-term negative consequences on the health, social, and economic well-being of the individual and the society. Despite this, globally, greater than 50% of children experience violence each year. Africa bears the greatest burden of violence, with 60% of boys and 50% of girls experiencing violence. Now, a nationally representative study in South Africa found that 20% and greater than 30% of children 15 to 17 years experience sexual and physical violence, respectively. Now, finally, within the birth to 20 plus cohort, a study found that 99% of children were indicated being exposed to or experiencing some type of violence by the time they were 22 years. However, majority of studies are based on cross-sectional or retrospective recall of violence experiences, with very limited studies, especially in Africa, that look at longitudinal patterns of violence. The aim of the study was therefore to generate physical and sexual violence victimization trajectories across childhood and evaluate early life factors predicting these violence trajectories. So we used data from the birth to 20 plus cohort. Now, this study recruited 3,273 children born within a 7-week period in 1990 in public health facilities in Soweto, South Africa. These children have been followed up into their 30s. However, for our study population, we will focus on children who are followed up between birth and 18 years. So on our exposure variables, we looked at early life factors, majority of which were collected at birth, but we also looked at some factors collected before the age of 5 years. These early life factors were divided into individual factors and family level factors. The individual factors were birth weight, sex, relative height and weight gain. And the family level factors included, for example, household social economic status, household crowding. For our outcome variable, we looked at children who had data on either physical or sexual violence in at least 2 of the 4 time points between 5 and 18 years. Now, these time points were selected because they had sufficient data on both physical and sexual violence, and also these time points had data on physical and sexual violence collected separately. Now, in total, 2,057 children were included in the physical violence analysis, while 2,051 children were included in the sexual violence analysis. Group-based trajectory modeling was used to identify children that followed similar patterns of violence across childhood. And multiple logistic regression was used to identify early life factors that predicted violence victimization trajectories. When it comes to our demographic characteristics, we find that slightly above 50% of the population were female. Majority of these children lived in low social economic households. They had parents with high school education. Now, when it comes to our trajectories, we found that a two-group model provided the best description of violence pattern across the time points between 5 and 18 years. What we found is that these patterns the two patterns were, however, different in terms of the shape of the trajectories. When we start with physical violence victimization trajectories, we found that children experiences of physical violence victimization increase as children are exposed to more environments outside of the home. When it comes to sexual violence victimization, there was a late onset of sexual violence victimization and a gradual increase in victimization experiences. However, for a high proportion of the population, experiences of both physical and sexual violence were limited to the adolescent period, followed by a decline in experiences of both physical and sexual violence. For 35% and 26% of children, their experiences of physical and sexual violence persistently increased into adulthood. When you look at early life factors associated with violence trajectories, if I start with physical violence victimization, we found that being female, residing in high social economic households, and having a mother with higher education were all protective against chronic or persistently increasing physical violence victimization trajectories in the adjusted models. We also found that relative height gain between the ages of 2 and 5 years was protective against chronic increasing trajectory group. However, due to large amount of missing data for this variable, it will not be included in the adjusted models. When it comes to sexual violence victimization, independently, living in a household with higher social economic status, having a mother and a father with higher education, and also living in less crowded households was protective against late increasing trajectory groups. However, after adjusting for our factors in the model, we found that none of these factors remained statistically significant, and only household social economic status shows marginal significant association with trajectory group. So, in summary, we found that approximately a third and a quarter of children in this sample exhibited persistently increasing physical and sexual violence victimization respectively. We found that both individual and family level factors predicted physical violence victimization trajectories. Now, just to expound on this, boys exhibit externalizing behaviors that might predispose them to follow the chronic trajectory group, and that's what might have made them to be more associated with chronic increasing trajectory groups compared to the females. Also, we found that maternal rather than paternal education was associated with physical violence victimization trajectories. Now, societal gender roles in most of the African communities place the responsibility of raising children and caregiving onto the mother that might have led to an association between maternal education. Additionally, poor linear growth in early childhood has been associated with delayed cognitive development, poor educational outcomes, and rapid weight gain, all of which are risk factors for physical violence victimization in childhood. However, much future studies need to look at this association adjusted for other factors. We notice that vulnerabilities to late increasing sexual violence victimization patterns were limited only to family level factors. In conclusion, our study found that children within the same environment can follow different patterns of violence victimization. Both individual and family level factors contributed to increasing victimization patterns. Our study supports existing literature that looks at the importance of quality nutritional support during first 1,000 days of a child's life in preventing stunting and mitigating subsequent negative outcomes on human development. Therefore, to be able to contribute towards prevention of violence, there is need for early and integrated interventions targeting poverty alleviation, parenting, and nutritional support. Just to mention a few of the limitations, the presence of large gaps between the data collection points on violence affected our ability to discern more heterogeneous patterns, and also the high proportion of missing data limited the inclusion of child growth variables such as stunting into our model. Now, to the strengths, the longitudinal nature of data collection allowed us to characterize violence pattern in our African setting. Secondly, the prospective study design allowed for shorter recall periods that minimize recall bias. Now, I would like to acknowledge my supervisor, Professor Kagura, who's here with us, and Dr. Naika, and also the Sexual Violence and Research Initiative for funding this work, as long as the other. Thank you so much.
Thank you. We'd like to call on Dr. Tozo Lagawaya to speak on understanding pathways to inspire aligned provisions and sexual violence outcomes in adolescence, a South African cohort analysis. 8 minutes.
Good morning, everyone. It's such a pleasure to speak after Lillian, who just did an excellent job in speaking about what leads to the different forms of violence. I will be doing the same thing in the context of South Africa, looking now at the protective elements. What can we do to kind of better understand what are the pathways towards reducing sexual violence? The lifetime prevalence of sexual violence within the African context is quite high. It can range up to 54%. Within South Africa, there's a latest study from the Optimus, which shows that for both males and females, the risk of sexual violence by the age of 17 is up to 1 in 3. And that there's different types of sexual violence, whether it's transactional, contact, or non-contact, they also vary by sex. There are multiple theories that can explain or try to make us think about what leads to sexual violence. This work is limited in terms of the theories that we apply in thinking about how dominance and how gender disparities affect how sexual violence occurs, and how the history of apartheid, where both violence is a form of conflict and as well as a form of freedom, have impact on how sexual violence occurs within the household and the community. It has been decades in South Africa specifically where we've had different policies that aim to look at sexual violence, sexual offense acts, as well as other child protection acts that allow us to kind of investigate this. Okay. Hi. Can you hear me? There we go. I can hear myself. Okay. So in 2016, what we had was something called the INSPIRE framework. And these were organizations, up to 10 international organizations, that gathered information from both low, middle income countries and high income countries to think about what are the different pathways to reducing sexual violence. And what the INSPIRE really reflects are the different layers in which sexual violence prevention has to encompass. There has to be laws that are first written and then implemented. We also have to think about how we shift our norms and values to these issues of power and dominance. We also have to consider how we create safe environments in avoiding hotspots, and then parenting and caregiver support, how those can form a crucial role in how we talk about sexuality and how we talk about disclosure when these incidences have occurred. Income and economic strengthening is a key thing that we need to reflect on as we think as well about the different pathways. However, when you look at sexual violence on its own form of violence, there's relatively less information on how this framework can lead to a reduction. We have much information on physical and emotional violence, but we don't have on sexual violence. And so we use a longitudinal study that started in 2014 and with 3 time points ending in 2019 to look at these factors. There are 3 forms of sexual violence that we look at, which is contact, non-contact, so just being asked to look at someone's private parts when you didn't want to, or someone show you their private parts when you didn't want to also in engaging for sex in terms of transactional sex, for goods, for better marks, or for food. We retrospectively then said, what are the study instruments that can reflect back to this INSPIRE framework? For parenting, we use a scale that's the Alabama scale that basically is what is used in parenting programs to assess if there has been an improvement in parenting. For income strengthening, we looked at cash grants, we looked at food security, we looked at whether or not you could afford basic needs, and then we also looked at whether or not you could afford school-specific needs. For education, this was just one variable we looked at, which was whether or not you were in school or you had completed the highest grade of schooling. We use the generalized estimation equation model specifically because it allows us to think more about the pathways to which sexual violence might lead. This is informed by work by Amber, who has really looked at what are the different ways that some of these programs have been designed, not specifically for sexual violence, but have contributed towards sexual violence reduction. And then the beauty of a GSME is that it allows us to use both latent and observed variables into thinking about what are the differences for the individual and how much of it is also due to measurement error. It also allows us to separate this assumption that our latent variables are also measuring the same thing through time. We can further assess that, and then we can also look at group estimates to see if they differ. In this case, I was interested in 6 differences. And so what we see here is that, I'll just concentrate maybe on, due to time, on the grants, is that fairly everyone in South Africa, well, there's a large proportion who's receiving social support, up to 89% by the end of the wave 3. Past week security was about a quarter, about 3/4 in this case. That was consistent through time, and that being in school differed by the sexes all the way as well up until the 3rd wave. What we do see, though, when we look at consistency, like the same people reporting access to this different Inspire provisions, the rates are not as high. So we see that, for an example, if you look on the income and economic strengthening, you look at food security, while 3/4 overall at each wave reported past week food security, consistently, we see that only 28% did that. What do we see for past year prevalence? We see that past year prevalence of sexual violence did differ by sex. We had females consistently higher at the first wave, but at the second wave and the third wave, the rates of past year sexual violence were comparable. I'm happy to speak about why that is. I do want to get to the results due to time, so I will leave that for a question. What we see overall, in terms of when we combine both males and females, we see that schooling had a direct effect in protecting against sexual violence. We also see that parental supervision had a direct association with reduction in the odds of experiencing sexual violence. We also see that being able to afford general necessities, so your school fees, your basic toiletries was linked with reduced sexual violence, and food security as well was also linked with food security. What we don't see here is an indirect pathway of social protection, which is at the far left on my screen overall. But when we look at these by sex, we see that for social protection, it has an indirect pathway for females. So females in this graph are in red, and males are in pink. And if you look at the far left, you see that in red, there's still an indirect pathway from school protection to making you more likely to afford school necessities, and therefore leading to a reduction in sexual violence. We don't see that for males, whereby the pink is faded out. And what this led us to think about is to remind us that much of sexual violence does differ by sex. And if you look at the socioeconomic differences within this graph, they lead to issues of thinking how we measure inequality and how we measure dominance and power within the space in South Africa. And it also makes us think about which of the regressions we used. And I'll speak more about that in a different space, where we looked at how it looked differently when you used a mixed effect, a GE effect, and whether or not in the same analysis we did an inverse weighting due to the different age groups for the males and the females. I'd like to thank all the funders who make this work possible.
Thank you very much. We'd like to call our third speaker from Brazil. We're speaking about relationship between women's economic empowerment and basic water sanitation and hygiene in the home. Welcome to the podium, Thiago Santos. Oh, can we have the presentation? Relationship between women's economic empowerment. Good.
Good morning, everyone. My name is Thiago Melo Santos. I'm here to present the work that I did at the International Center for Equity and Health in Brazil. I'm trying to answer what is the relationship between women's economic empowerment and basic water sanitation and hygiene, which is also called WASH, in the home. So we know that women face disproportionate effect of lack of WASH in their homes. They have increased vulnerability to infection during menstruation and childbirth. We also know that they are exposed to physical and sexual violence when using shared sanitation facilities, and that they are primarily responsible for water collection and wash domestic labor in most countries, which can lead to spinal injury and neck pain, and less time available for education and income generating work. There is a lot of body of evidence in the literature showing that women's empowerment and WASH can actually represent a positive cycle, where more empowered women will have more control of economic resources and decision-making, therefore accessing better WASH in their houses. And when they have better WASH, they have more discretionary time, education and employment, and access to new roles that they can use, and that eventually leads to women's empowerment. Nevertheless, the evidence is still sparse and very context-specific. So our objectives here were to create a women's economic empowerment score, specifically related to economic autonomy and decision-making in the context of low and middle-income countries, and investigate the association between that score and basic water, sanitation, and hygiene in the household. We use data from 31 demographic and health surveys from 2010 forward that collect information on basic WASH services in the household and women's empowerment. Women here specifically a set of married or in union women aging 15 to 49 years old. The indicators that we used were basic water, having an improved water source with water collection time of less than 30 minutes, basic sanitation, which is having an improved sanitation facility that is not shared with other households, and basic hygiene, which have a hand wash facility that has soap and water. And the Women Economics Empowerment Score was from 0 to 5 based on 5 indicators. The first one is whether women have a bank account that they use, whether they have a mobile use for financial transactions, whether they have a paid work and they get to decide on how to spend the earnings of that work, whether the partner has also a paid work and she decides on how to spend his earnings, and whether she participates in decisions about major household purchases. So our sample is of 278,000 women, so it's a very large sample from those 31 countries. First thing, just a description of our score. You can see that this distribution centers around 2, which is a very low number, and 17.8% of the women that we investigated had scored 0, meaning that they had none of the conditions that we investigate. We also want to highlight that 10% of the wealthiest women in our sample and 3% of those with higher education also had a score 0, meaning that even women who are in very wealthy households and who are highly educated can also be at level 0 in this score. I'm going to present the results using this plot. It's called an equiplot. Here I have a hypothetical example just to get you accustomed to the figures that I'm going to show. So first, we're always going to present 3 groups. In darker purple, we have women with lower levels, 0 and 1 in that score. We have blue, the intermediate, 2 and 3. And then we have women in the green, which is the higher level of economic empowerment. All the plots are going to show the prevalence of basic water, sanitation, and hygiene. And in this scenario here, we have women in lower economic empowerment at 40% and at higher in 80%. A measure that I'm also going to talk about is called the slope index of inequality, which is the predicted difference in the WASH prevalence between the most and least empowered women. So in a scenario like this, you could expect, for example, SII of approximately 40 percentage points. And it's positive, indicating that better WASH is associated with more empowered women. So first, let's look at water. Here, we are separating the rural from the urban environment. And as you can see to the left, we usually see the darker groups, meaning women with lower empowerment. And to the right, we see the greener, lighter groups. So what we can see is that basic water is indeed associated with women's economic empowerment. And we see better basic water in those women live in households where women have more economic empowerment. And as you can see, the differences, the inequalities that we observe between the countries that are investigated, they are larger for the rural environment than they are for the urban. And we have a median SII of 15 percentage points for the rural area and 6% for urban areas. The urban areas, it's smaller because the prevalence of basic water tends to already be much higher in those environments. For sanitation is where we see the largest inequalities here, with a median SII of 13 percentage points for rural areas and 21 percentage points for urban areas. And I want to also highlight the case of Burundi, the urban areas of it, where women with lower economic empowerment, only 37% of them have basic sanitation in their households, compared to women in the higher level of economic empowerment, where 81% of them have basic sanitation. Finally, for hygiene, we see the opposite that we saw for water, where in the urban environments is actually where we see the largest inequalities here. For the rural areas, it's an 8 percentage point median SII compared to 19% in the urban environments here. So what are the key messages that I want you to take from this presentation? First thing is that more economically empowered women, they tend to live in households with better wash access in general in the countries that we investigated. And we also saw large inequalities throughout, between and within countries. And we saw even larger inequalities specifically for sanitation. Our results are adding to the growing body of evidence of the relationship between WASH and women's empowerment. That being said, it's very important to highlight a lot of the limitations that we have with this work, because even though we have access to information of women's education and household wealth, we cannot simply control for those things. Because, for example, when we look at wealth, when we look at throughout the life, women that come from wealthier households, wealthier families, they tend to have higher empowerment themselves. But since they are more economically empowering themselves, they can also contribute to their household wealth. So they are both confounders and mediators in these associations. So we have done some sensitive analysis where we controlled for both education and wealth. The inequalities, they are reduced, but they do not disappear. But that kind of control is not adequate here. So according to what we're seeing as well in the qualitative literature, there seems to be an important association between the two groups. What we need now is longitudinal studies that can investigate both the directionality and the confounding structure of this relationship, and eventually create interventions that use this association that we found. Finally, I'd like to acknowledge both my PhD advisor, Louise, who is there, who helped with this work, also my PhD advisor in Australia, Megan Boren, and also all the funding institutions that help with this project, the North Institute for Global Health, the Bill and Melinda Gates Foundation, the Wellcome Trust, and the CAPS Foundation in Brazil. Thank you so much.
Well done, thank you. The next presenter will be talking about the courses for 30 days readmission and accuracy of the LACE index in regional Victoria from Australia, Reinhard Dreyer from Russell Stellenbosch, South Africa.
Is it working? Yep. Good morning, everyone. My name is Reinhard. I'm a specialist physician, clinician, and researcher from Victoria in Australia, and today I'm just presenting one of our projects that we published earlier this year looking at the causes of 30-day readmissions and the accuracy of the LACE index in regional Victoria, Australia. So just a bit of background. So hospitalizations and rehospitalizations are really high drivers of cost, and 30-day readmissions are often used as a quality metric because readmissions are often quite expensive, more complex, and the cost of these admissions are more than the original index admission. Now, as a clinician and funders, we often try to find ways to reduce the costs, but without sacrificing care. So there's various risk stratification tools that's available that we can use to identify these high-risk patients that is often used on the day of discharge from an index admission, and just calculate what is your risk of coming back or dying within the 30 days after hospitalization. Now, 3 of the most commonly used is the hospital score, which consists of 8 parameters, the PRA score, and probably the most widely studied and used is the LACE index, which is a very simple tool consisting of just 4 parameters, which is your length of stay in days, the acuity of admission, whether it was a planned or a non-planned admission, your Charleston comorbidity index, and the number of emergency department visits you've had over the past 6 months. It's a score between 0 and 19, and if you have a score of more than 10, you are classified as having a high risk of readmission or death within 30 days. Now, this project had 2 arms. Was first of all just to look at the demographics of our area, Also just assess whether this is a risk stratification tool that we can actually use. This image is not from my publication. And the second part was looking at just why people come back within 30 days. So there's various frameworks and classifications available, but they're administrative and they're quite complex and have low value for me as a clinician to use, looking at potentially avoidable or unavoidable causes. So what did we do? We used a nested case control design and looked at the 30-day readmission status as the outcome of interest, and we then classified groups into cases, somebody that had a discharge within 30 days before, or sorry, death as well, or controls that had no discharge within the 30 days. It was a period of 2 years. It was performed in a regional setting in regional Victoria and Australia, and we looked at all inpatient patients that were discharged. The analysis I've put on there, it was done by the University of Stellenbosch, as this was a project that was a collaboration between the health service I work for and the university where I've done most of my training as a background. Now just a little bit about the development of this project. This has actually been done before, and when we did this project about 2 years back, we actually found a good C statistic for this tool using a cutoff of 10. And this was just a follow-up using a more defined population of medical patients and not all admissions. What we did is we extracted data from health information services. We transformed all the ICD-10 codes into a risk score, which was quite a challenge. And then we only did a record review for a very small number of patients that actually came back to determine why they came back and classify them using this new stratification, classification. So just going into some of the results, I'm not going to go too much into them. We had 2,023 cases, controls with 134 cases, where the main differences between the groups that the cases were predominantly male. As you can see, there's 60% versus 50%. They had a slightly higher age. They had a slightly longer length of stay of 5.8 days compared to 5.1. They also had more comorbidities, particularly 3 or more comorbidities. And in general, their LACE index using a score of 10 or more was also higher. Now, just looking at the individual components of this index, is that the main drivers of the higher risk was the length of stay, as well as somebody's Charleston comorbidity index. The acuity scores were the same across the groups because we used all patients that with emergency admissions, and the emergency department score was not different between the groups. When we had a look at why people came back, most of them came back within 14 days, which tells us that there was something that possibly could have been done to prevent them from coming back. Something was unresolved. Sadly, unfortunately, the tool did not fare as well in this particular study, with an area under the curve of only 0.58 for a cutoff of 10. However, when we analyzed and used a cutoff of 12, which is not this traditional cutoff that is used for this tool, it did actually increase to 0.79, which means that we can use the traditional 10. Doesn't fare as well. We needed additional parameters, but we can actually use it as a higher cutoff in our setting. Now, just briefly on the classification, and again, there's very good classification tools. We've got the Australian framework that we use for readmission classification, but for me, like I said, it's got low value because it's about 20 different reasons and it's administrative, and I just cannot use it as a clinician. So what we did is we just simplified it, and it correlated, our classification tool correlated pretty well with the Australian framework, and we identified that nearly 40% of patients who were readmitted had potentially avoidable reasons for coming back, which were predominantly avoidable events like hospital infections or pressure injuries, or, for example, they might have had other side effects or problems like nausea, vomiting, or constipation. Now, just going into conclusion, what did we find in all of this? So people had a higher risk of readmission if they were a biological male, if they were over 65 years old, had 3+ comorbidities, or a high Charleston comorbidity index. Nearly 2/3 of readmissions occurred within 14 days, which is quite a high number. There was also a positive linear correlation with a higher LACE score and the risk of readmission. So for each 1 point increase in someone's LACE index, they had an odds of readmission increase by 11%. Now just looking at the actual tool, again, as I said, using a cutoff of 10 didn't fare as well. So it did not on its own accurately predict a risk of readmission. We needed to add additional variables, but when we increased this to 12, it actually fared pretty well. And then just lastly, the classification tool, it correctly identified all admissions according to the Australian framework and identified that nearly 40% of these readmissions were potentially avoidable. Now, what are we going to do next? We've actually already incorporated the LACE index into our discharge summaries. So this is something that gets done on the day of discharge, a little pop-up box for a junior doctor to say this patient is at high risk of readmission. What you do with it, we're still deciding. We're also looking at whether the classification tool, we will need to do a multi-site study. And then lastly, we're also going to look at does early versus standard follow-up actually reduce readmission. Thank you.
Thank you very much. Our last presenter for this morning is a lady, Kendra, from Nebraska. We're talking about transportation barriers and poor health. Thank you.
Hello, I'm Kendra Ratnapradeep from the University of Nebraska Medical Center. To begin with, I don't have any disclosures other than the fact that this was internally funded by my university. So I will be talking about transportation. To contextualize, transportation needs to be contextualized. Nebraska is located in the center of the United States, and so we know that cost and transportation are known causes of delaying access to medical care in the United States. We also know that delaying access to medical care can impact overall health. We previously found that about 38% of Nebraska adults have ever delayed medical care, with about 4% of that attributed specifically to transportation. Delays in care seeking or interruptions in medical adherence lead to worse health outcomes, but transportation is a social driver of health. And transportation can impact more than just on accessing health care, but also on accessing to food and other essential services and work. And so we wanted to characterize the landscape of transportation in Nebraska and also to examine how transportation was actually being assessed. Across a lot of different national surveys and cohort studies, there are lots of different ways about asking about transportation barriers. And so we wanted to narrow that down and figure out what exactly was happening within transportation and how that was associated with poor health outcomes. So a little bit more context. Within Nebraska, we have two large urban centers, both located on the eastern part of the state, Omaha being the largest metropolitan area in the state and the capital of Lincoln. And most of our state is very rural and agricultural. We have a primary highway that goes across the southern part of the state that follows the Platte River. So this was a cross-sectional study from 2020. We did try to stratify based on urbanicity, so we stratified for our mailing sample based on large urban areas, small urban areas, and rural areas. We had about a 21% response rate, and we were calculating prevalence odds ratios. Nebraska is not particularly racially and ethnically diverse, so we did try to oversample for areas that had more diversity. And we also included both English and Spanish in our mailings to try to increase representation. So jumping right into the results, when we waited for our survey methodology, we found that about 8% of Nebraskans self-reported fair to poor health. In our unweighted survey, this was about 15% of the raw data before we weighted, and so with the weighting, it actually decreased. To give you a sense of how we were assessing transportation, we used a lot of different metrics with different time points as reference. We also created a summary measure, which is the one at the top. So if people had one or more of the transportation issues, there was about a 45 to 46% of respondents overall before waiting that had one or more transportation issues. After we applied the survey weighting, that reduced to about 32%. The most common transportation issues were travel distance of 20 miles or more, 15 miles or more, or 20 minutes or more of travel time. And the least common transportation issue was not having a working vehicle. About 1.3% of households did not have access to a working vehicle. That was down from about 4% of the raw data before survey weighting. Other measures of transportation that we assessed included, in addition to travel time and travel distance, difficulty getting somewhere by car, again, based on self-report, not usually driving oneself to medical appointments, ever delaying care, not having a valid driver's license, any transportation problem, self-defined, in 2019, which was the year before the survey, or in the past 30 days, or ever using non-emergency medical transportation, which is a subsidized, low-income, Medicaid-provided transportation to medical appointments only with documented transportation difficulties. To give you a sense of the survey responses, these are the covariates that are weighted. So we had a distribution of both males and females, different age ranges. Again, Nebraska is predominantly white and predominantly non-Hispanic. But we did consider all of these as potential covariates in our analysis. So first we conducted unadjusted models to see how each of these transportation measures were associated with overall poor health, and here you can see the unadjusted prevalence odds ratios. You can see that almost all of those transportation measures were associated in crude analysis with overall poor health. The only one that was not significant was the travel time. When we adjusted for each of the covariates that was previously presented, we did find that there were some changes in the adjusted prevalence ratios. So we modeled each transportation outcome separately, adjusting for sociodemographic factors that were significant in our crude analysis, which included age, ethnicity, marital status, rurality, education, income, and having a chronic health condition. The transportation measures that remained significantly associated with poor health, when adjusted, included our summary measure of any transportation problem, not usually driving oneself to medical appointments, ever delaying care due specifically to transportation or distance, not having a valid driver's license, and any kind of transportation problem in the past 30 days. Here's an example of the fully adjusted model for any transportation problem. So you can see how that works in terms of the adjustments. So age no longer was important in the model, but Hispanic ethnicity and marital status were, as well as expectedly any health condition, any chronic health condition. But even considering any health condition and these other factors, any transportation problem was almost a twofold increase in poor health. So in summary, most transportation barriers are uncommon in Nebraska. Only 5 remain significant after adjustment. And the strongest associations that we saw were delayed care and transportation problems in the past 30 days. Our next steps are to develop a multi-component travel barrier and being much more thoughtful and specific when asking questions about transportation and its role in healthcare. Thank you.
May I ask us to please give a round of applause to all the speakers this morning and presenters. Thank you, as distinguished presenters this morning. Well, we have come to Q&A, and we have just 10 minutes for that. So please, the microphone is there, and we would like you, if you want to, just by show of hand, we can line up one, any other person, and just go to the mic. And please make it very short. No stories. Yes, thank you. And next person can
Hi.
go there. And we'll
No
take all the questions, 5,
Okay.
and we let us know which speaker it is for, and we can quickly, they will answer when they have taken all the questions, rather than on a one-by-one basis. Thank you.
Thank you. No stories here. I have two questions. First question for Lillian. I'm curious, how did you calculate the household socioeconomic status? I know we struggle to calculate that composite variable. And for non-Tokozo, about the parenting scales. So I see 6 Likert scale and 10. Those scales have been developed in high-income countries for English speakers. Did you test it, adapt it, and how was the experience using those? Because I know in South Africa it's not quite easy to use a more than 5 points Likert scale. Thank you.
Hello, my question is for Thiago. With regards to measuring empowerment, especially for the rural women, I would like to know, does the absence of paid work really imply that they are not economically empowered? Because I have a sense that, especially in rural areas where women are involved in more probably farming activities that are not a month-to-month paid activities, how do you then classify such groups? Yeah, okay.
Gerard Finnegan from Health and Emergencies International. My question also goes to Tiago. Amazing piece of analysis, congratulations. I was just wondering whether your data showed any association with female-headed households, whether you're able to draw anything out of that, or similarly whether you're able to identify households where the female was the primary caregiver, that's either caring for elderly people or alternatively caring for much younger people. Thank you so much. Thanks for all the panel members. Thank you.
Hi, my name is Veronica Weitzel. I'm from Switzerland, from University of Bern, and I have a question from Reinhard. So I was a little bit surprised when you showed the Kaplan-Meier curve for the readmissions by different groups. So my question is, did you also look at cause-specific cumulative incidents that differentiates between death and readmission and accounts for the competing risk between the two? I think that would be also very interesting to see. Cause-specific cumulative incidents, if you looked at that would account for competing risk of death when you're looking at readmissions. Thank you.
Hello, my first question was to Lillian. The trajectory analysis, the descriptive, was really, really powerful and really, really interesting to see. I was just really struck with these two groups, this sort of trending increasing and then this trending decreasing, and how dramatic that decrease was in that second group. So sort of that drop off completely almost to zero, and in that any experience of violence. And so just to understand whether that maps onto the literature and whether that was also, I couldn't quite tell if it was a kind of whether you'd used methods to choose those two groups and how those two groups were chosen. And then I guess to Tiago, with the economic empowerment, I'm just trying to think through the kind of next steps. In a sense, access to water and sanitation is so driven by community infrastructure and kind of how, when we think about economic empowerment and women's economic empowerment, are we separating that from the resources that they have available to them and kind of the broader structural determinants? So just a reflection on that.
Thank you. One more final person is there. Okay, because we have 4 minutes to wrap up this, and the speakers have not yet responded. So, very brief.
All right. Fumi Fawale from University of Ibadan, Nigeria. Question is on the readmission, and I found that very interesting and wondered if you would have found different results if you used a lower level of healthcare, maybe secondary or primary. Would you think you would still get the same results? Thank you.
All right, so we'll start with Lillian. She has 3 questions. Tiago has a number of questions. And the other 2 people don't have questions, so quickly respond.
Thank you for Thank you for your questions. I'll start with the first one. Now for the household social economic status, we used household asset scores. Some of the questions were asked is either presence of a refrigerator, presence of a car, presence of a television. Then from these scores, we were able to develop tertiles and divide it into 3 groups, which was low, middle, and high. So to the second question, I think you asked whether the drop in adolescent limited has been seen in literature. We found that literature mostly conducted in the global north found the presence of an adolescent limited period, and also from cross-sectional studies, we have found that experiences of especially physical violence tend to decline after mid-adolescence as age, with increasing age, maybe it's because of maturity, but also how the groups were developed is that we used several iterations to be able to determine the number of groups. Now, we tried 1 group model, 2 group model, 3 group models, and the decision on number of groups was based on lowest Bayesian information criterion and highest entropy. And we also tried to look at several polynomial orders, starting with the linear, quadratic, cubic, just to see which shapes best describes our valence characterization across the periods. So that's how we were able to come up with the 2 groups. I hope I've answered your question.
Yeah, so for the scale was 5 Likert scale. We did do training. The Alabama scale has been used all around South Africa, and it has been validated. And in the study, we saw a good alpha Cochrane of about 0.85 at each time point, and we also assessed whether or not it was measuring the same thing continuously also by 6. So in this particular case, the validity was there.
Okay, 3 questions. Try to answer them very quickly. First one about empowerment in rural areas. We initially included some variables related to the rural areas, but then in the end we found that those 5 questions together, they provided some of the best characteristics, and in all the different countries they tend to follow a very similar pattern, both for urban and rural areas, so we decided to just keep them and use the same. Female-headed households, that's a very interesting question. We started to look at that, but the problem is that that information considers a lot of things that has behind it, because you can have very different scenarios of what it means for to have a female-headed household. It could be both an indicator of a very empowered woman that's leading the household, or also women who are disenfranchised, they are widows in a very different scenario. So it takes a lot of work to actually separate that, and it was beyond the scope of this study. And the third question, which was about community and infrastructure and environment, that's a very good point, but I would say there's also a lot of work that can be done at the household level. Some of the interventions that we see, they very well intentioned, but then in the end they're not aware of gender and how that can plays out. So just give an example, there was this major intervention that was about building latrines, going to households and offering help to build that, but when they arrive in those locations, women were the ones in the household and they said, yes, I would love to do that, but I cannot say yes now because I have to ask my husband, I have to go get permission. So the barrier there was not necessarily something related to the wealth, but about that empowerment and women being able to make those decisions. So even though there is a lot of things that happen at a broader spectrum, even in the household, there's a lot of things that we can work with.
Thank you very much for the question. Yes, we did. When we did the survival analysis, I believe the statistician did do that. Unfortunately, I would not be able to give you the statistics because I do not understand it. But what we did discuss at the time, that they did look at the cumulative incidence. So I'm sorry, I can't give you any more information than that. On the second question, this is one of the reasons why risk stratification tools are quite interesting, is because they're very flexible. So there is actually an extension of the LACE index, which is called the LACE Plus index, which actually looks at the regional area, secondary or tertiary level, and actually also looks at the level of educating that is done in that hospital, whether it's a tertiary or a secondary teaching hospital. So again, all of these are extensions, but obviously the more parameters you add to any risk tool, the less it is likely to be used by somebody, on the ground. So that has been studied. It was not done in this particular study.
Time has gone, but the last one, the question was, you had a variable, didn't seek care. Was this a transportation problem? A variable, you said, didn't seek care. Was this a transportation problem also? How?
So we did have the variable about not seeking care due to transportation, and so it was worded pretty much like that. Did you not seek care due to a transportation problem?
On behalf of all of us, can we please give these great presenters a round of applause? And while we'll ask you to return to your seats, thank you very much for this first round. I wonder us were at the plenary yesterday. The one message was move. So can we do some moving before we start the second session? Can you please move, even if it's 1 minute, stretch, move your legs. You reduce the risk of deep venous thrombosis, and then we're ready to go. Again, the message here is very clear. We have learned, so let's go back home, see what we can replicate, see whether it's applicable, and continue to improve the body of knowledge. All right.
Thank you very much, my co-chair. We can sit down. Thanks very much, Prof. Udusanya. Our next panel, please come through. Our next panel, so we can continue. And just want to make sure everyone is here. Nani, Adaleg, Amand, Luca, William, Shirut. Okay, Shirut is the last one. Okay, thank you. We jump right into our presenters. I would like to invite Nanin Adareg. Nanin Adareg is presenting subnational estimation of population size for female sex workers in South Africa. Nanina Adareg, University of Bern, Switzerland. Thank you. Welcome.
Thank you. So let me start my presentation with asking a few questions. How many female sex workers are there in South Africa? How many in the Northwest Province, which is 1 out of 9 South African provinces? How many in Central Karoo, 1 of 52 districts? And how many in Alfred Duma, 1 of 213 sub-districts or local municipalities? Well, why do we need to know these numbers? Female sex workers are a high risk or key population for HIV, and of course not only for HIV. And there is an increasing acknowledgement that it is important to have estimates for key population on a small area level in order to plan tailored intervention, allocate resources, and ensure equitable and equal service access. But it's very difficult to get these estimates since female sex workers are a hidden population due to the ongoing criminalization and stigmatization. So what do we know? Well, if you do a short or longer search, you will most probably find the answers to the first 2 questions I asked, because there are some studies that report population size estimates on a national or provincial level. For the specific district or sub-district that I randomly chose for my 3rd and 4th question, you will not find an estimate. But for other sub-districts, you might have more luck, because how these studies usually work is that they first produce estimates on a very small area level, so let's say for a few sub-districts or even only for towns within sub-districts, and then they extrapolate to the national level. However, what is a bit of an issue is that it is very difficult to compare these estimates since the studies differ in many aspects, including the estimation method they use. And what is even the bigger issue is that for most sub-districts you will not find an estimate at all. So there is a lack of synthesized PSEs on a sub-district and district level, and this is why we wanted to estimate the population size of female sex workers in South Africa on a subnational level by leveraging data from different existing sources. To do so, we reviewed all studies that reported a PSE for female sex workers on a sub-district or lower level. We extracted relevant information and merged it to demographic data on sub-districts. We then fitted a Bayesian hierarchical regression model. Our outcome of interest was the proportion of sex workers among females aged 15 to 64, so kind of the working female population. We included several fixed effects. I will come to those when discussing the results, and also some random effects and weights. We used the model to predict the proportions of sex workers at a sub-district level, and then we aggregated sub-district level predictions to derive district, province, and national level estimates. We found 5 studies that reported PSEs for female sex workers. They reported in a total of 115 estimates. However, we had to exclude quite a few of them due to various reasons. So we ended up with 74 estimates that we included in our regression analysis. They ranged between 1.2 and 5.8% sex workers among females aged 15 to 64. If we look at the spatial distribution, we can actually see that we only found an estimate from 45 sub-districts in 31 districts. And as you can see by the color, most of the time only one published estimate was found. However, there were some sub-districts where we did find more, sometimes up to 10. Let's come to the regression analysis. On the left-hand side, you can see the raw data, the published proportions. And on the right-hand side, our predicted proportions, so the model output. Our model suggested that sub-districts that bordered a neighboring country had a higher proportion of sex workers, that sub-districts which consisted of secondary cities had the highest proportion of sex workers, followed by those consisting of larger towns, smaller towns, metros, and mostly rural sub-districts. There was also an association between having a lower population density associated with higher proportion of sex workers, but this was only evident in rather urban sub-districts. There was also some differences between provinces and generally quite a large variability, as you can see by the colors. So our predicted proportions ranged from 0.2% sex workers here in the Ulundi sub-district or local municipality up to over 5% for Lefalale sub-district. This large variability was accompanied by quite high uncertainty, which you can see here on the left-hand side. So what is shown there is again the predicted proportions, but now not on the map, but just ordered by size and accompanied by the 95% credible interval. And I just wanted to show you that there is quite a big uncertainty in these estimates. If you want to allocate resources or plan an intervention, you're probably not really interested in the relative level, but you want to know absolute numbers. So this is how the proportional numbers translate to the absolute numbers of female sex workers. And I actually just realized this morning that this map would have been more informative if I did it on the log scale, but I didn't want to stress IT with handing another presentation in this morning. But anyways, what we can see is that while the large metros, such as Joburg and Cape Town and the Durban area, didn't really have a high proportion of sex workers on the relative scale, these are now the areas where you find most absolute numbers of female sex workers, which makes kind of sense because it's also the areas where most people live. On a district and province level, a lot of the variability gets aggregated out, so there is less variability here. On a district level, we find a predicted proportion ranging between 0.2 and 2.5%, and on a province level between 0.4 and 1.3%. For the sake of completeness, I also show here how this translates into absolute numbers. So for example, on the province level, our model suggested the lowest number of female sex workers in the Free State province with around 4,000 sex workers, and the highest number in KwaZulu-Natal with around 51,000 sex workers. So to sum up, we found a large variability in the predicted proportion of sex workers on a sub-district level, which was somewhat reduced on a district and province level. This large variability was already seen in the published estimates, so this raises questions on the quality of those. Is it true variability or is it just biased estimates? We found high uncertainty in the estimates, and we are actually at the moment trying to reduce this uncertainty by looking at other predictors we could put into our model, trying to include routine prep data on female sex workers and also looking at spatial correlations. I would like to finish my presentation with giving you the answers to the first 4 questions I asked. So our model suggested that 0.9% among all South African women aged 15 to 64 are sex workers. This translates to around 177,000 sex workers. 0.5% in the Northwest province, which is about 6,200 sex workers. 2.1 in Central Peru, or 500 sex workers, and 1.6 in Alfred Duma, which is around 1,800. And with that, thank you for listening.
Thank you very much, Nanina, for the presentation. We'll go next. Amandi Hilai Hewich from Flinders University, Australia, looking at changing the narrative in indigenous kidney health. Thank you.
Good morning, everyone. My name is Amanda Harry, and I'm a final year PhD student from Flinders University. I'll be talking about chronic kidney disease in young Aboriginal people, findings from the ARDAC study today. This work was undertaken by a big research group, the ARDAC team, and I would like to acknowledge their contributions and the dedication of the ARDAC study participants. Before I begin, I would like to acknowledge that this work was carried on the traditional lands of Ghana Yurta, Adelaide Plains in South Australia. I'd also like to acknowledge the traditional lands across New South Wales from which data for this study has been collected. I'd like to pay my respects to elders past, present and emerging across these lands. In Australia, it is customary for us to acknowledge traditional lands prior to any presentations. Aboriginal people are the oldest continuing culture in the world and have had their own set ways of managing health prior to colonisation. The impact of ongoing colonising practices has increased the risk of chronic kidney disease, from here on referred to as CKD, in Aboriginal communities. CKD occurs when the kidneys are unable to filter blood normally and, if left untreated, can lead to adverse health outcomes. This figure from the 2021 Australia-New Zealand Dialysis and Transplant Report showed that the relative incidence rate of treated kidney failure for Aboriginal patients, particularly Aboriginal females, as shown in green, is much higher than the general population at all ages. This figure also shows that this disparity begins in early childhood, which is defined by the World Health Organization as young peoples. Previous national studies in Australia have underrepresented young Aboriginal peoples, and as such, there is missing longitudinal population-based studies for this population. This brings me to the ARDAC study, which stands for the Antecedents of Renal Disease in Aboriginal Children. The ARDAC study was initiated by an Aboriginal Health Education Officer, Ms. Rita Williams, when she was caring for a 16-month-old Aboriginal baby with kidney failure and requiring kidney transplant, a condition that is usually seen in older adults. The ARDAC study is grounded in Aboriginal health concepts and is guided by a strong investigator advisory committee nexus. Previously, we have shown that kidney health may be preventable in childhood. This slide presents a flow of the ARDAC cohort. Phase 1 began with around 2,000 young children. Biomedical data on the young children were retained whilst the cohort was replenished with additional participants who were age matched to the existing cohort in phases 2 and 3. During the data linkage process, 15 participants were excluded due to insufficient information for the linkage. And as a result, the final data linkage cohort consists of 3,743 participants, with just over 57% identifying as Aboriginal. This study aims to estimate the cumulative incidence of CKD among young Aboriginal people and to understand risk factors for development over time. The ARDAC study is based in New South Wales, Australia. Our study included participants across urban, regional and remote New South Wales from over 60 participating communities. The The ADAC study has had 3 phases of biomedical data collection. However, in phase 4, due to challenges in follow-up, the ADAC cohort was linked to 20 administrative and national datasets using standardized probabilistic data linkage methods. This data linkage extends the scope of our study with 27 years of follow-up, making the largest data linkage study on the kidney health of First Nations people internationally. To undertake our analysis, we created a case definition using various linked data sources. ADAC participants meeting any of the following criteria were considered to have CKD: a UACR of greater than 3.4 milligrams per millimole at least once during the cohort study, plus a pharmaceutical benefits data entry for a CKD-related medication, coding for any stage of CKD as either a primary or secondary diagnosis from the New South Wales and ACT hospital data using ICD-10 codes, entry in the Medicare dataset for a service relating to CKD, self-report in the ADAC social demographic survey, and/or coding for CKD as the main or other cause of death. Some baseline characteristics. 50% of young Aboriginal people were female. The median age for Aboriginal participants was 11 years old. Aboriginal participants had a lower socioeconomic status, and 16% of Aboriginal participants lived in major cities. Aboriginal participants are also more likely to be living in remote/very remote areas. And based on the anthropomorphic measurements collected at baseline, 17% of Aboriginal participants had obesity. Aboriginal participants also had a lower mean birth weight and a slightly lower mean gestational age. In total, 52 young people met our case definition for CKD. The graph on the left shows the cumulative incidence of CKD by Aboriginality over time. Whilst non-Aboriginal people have an earlier onset of CKD after around 10 years of age, the cumulative incidence of CKD for Aboriginal young people, as shown with the black line, is consistently higher at all ages compared with non-Aboriginal young people, with this being more evident at the age of around 15. The figure on the right shows the cumulative incidence of CKD stratified by both gender and Aboriginality. Notably, Aboriginal females, as shown with the dashed black line, have the highest cumulative incidence across all groups. Aboriginal males have a later onset of CKD compared to other groups. Non-Aboriginal females have a gradual increase over time, and non-Aboriginal males have the earliest onset of CKD, but their progression is slower over time. These findings indicate that the risk and progression of CKD vary across different demographic groups, which highlights the need for tailored strategies. We conducted a survival analysis model to understand factors influencing CKD in our cohort. We found that Aboriginal young people and females have a heightened risk for CKD, although these were not statistically significant. We also found that out-of-regional living and remote/very remote living increased the risk of CKD for young people by more than 3 times compared to living in major cities. Young people who had ever been obese prior to meeting our case definition for CKD were nearly twice more likely to develop CKD than those not obese. These findings will be provided to our partnering communities to foster self-determination so that they can address the risk factors identified and take proactive steps in improving health outcomes. Given that obesity is a modifiable risk factor, this presents an opportunity to intervene and address this from childhood. These figures show that the cumulative incidence of associated risk factors, including obesity, hypertension, cardiovascular disease, and diabetes, which are interconnected with the development of CKD in young people, is higher at all ages than CKD for both Aboriginal and non-Aboriginal young people. However, the cumulative incidence is slightly elevated in young Aboriginal people at all ages. As Aboriginal young people are experiencing slightly higher rates of these risk factors, the potential for developing CKD in later life becomes higher. Addressing these risk factors holistically and increasing earlier screening can result in improving health outcomes. Although our results are still primary, it provides crucial insights into the early life risk factors for those under 25 years, which has been missing in the Australian context. Our findings indicate the importance of CKD screening from an earlier age due to the asymptomatic nature of the condition, and we also emphasise the need for increased funding for Aboriginal communities so that they can develop culturally safe health promotion that can be used to reduce the burden of CKD in communities. I'd like to just acknowledge Ms. Rita Williams for her unwavering commitment in understanding health issues, my 4 PhD supervisors, ADAC study investigators, research team, Advisory Committee, and our partnering organisation, and most of all the other study participants. Thank you for listening.
Thank you very much. Great presentation from Abandi, from Flinders. We move straight to Luca Kegelon from University of Trieste, Italy, talking to us on allergic reactions against lanolin. Thank you. Welcome.
So this is for going now? Yeah. Okay. Hello to everybody. I'm going to present something a little bit different from the, let's call it mainstream, something an intersection between occupational medicine, pharmacoepidemiology, and allergology. So I work in Trieste, northeast of Italy, by the border with Slovenia. I have no conflict of interest, and I'm going to present a study on sensitization over the course of 25 years in a multi-center cross-sectional study on 4 centers in northeast part of Italy. So a little bit of a background. Allergic contact dermatitis, for those of you who may not be familiar with that, is a type 4 hypersensitivity reaction triggered normally by an aptan, which is an incomplete molecule that needs to combine with a bigger one, like normally a protein, in order to become immunogenic and trigger sensitization. Even a singleton event that needs to occur at least 2 weeks before development of dermatitis is necessary to trigger the allergy. So although being questioned for a number of reasons, mainly the so-called clinical relevance, the patch test remain an imprescindible and a gold standard tool to diagnose contact dermatitis. The clinical relevance is basically a subjective assessment of the clinician, who may say, okay, this guy or lady is positive, but I don't think that this has anything to do with the dermatitis he or she has. Sorry. So lanolin. Lanolin, what it is lanolin word is a combination of 2 Latin words, wool, lana for wool, and oleum, oleo, and basically is secreted by the sebaceous glands of sheep and can be extracted from the respective wool with a physical-chemical procedure first patented back in 1882 in Germany. The composition of lanolin is predominantly made of high molecular weight esters, and that's the reason why it is considered a wax rather than a fat. And for the emollient and hydrophobic properties, lanolin is widely used in skincare products, as well as to soften leather clothes or shoes. The first episode of contact allergy to lanolin was documented in 1922, following application of a skin. And after a number of case reports, the first patch test was performed in 1929. So we're talking about 100 years ago. So as for all aptans, lanolin is affected by the so-called problem of clinical relevance. In addition to that, the problem is that different derivatives are used for patch test, and some of them, like Amercol, included in the North American standard series, is indicative of higher rates of false positive results, because the prevalence there is higher compared to in Europe, where lanolin alcohol 30% is consistently used. So regardless of this, lanolin was named Allergen of the Year last year by the American Contact Dermatitis Society, because basically the prevalence of allergy in children and adults in relation to use of personal skincare products for skin conditions. So the present study, in view of all of this background, we decided to bring the evidence from Italy, doing a multi-center cross-sectional study over the course of 25 years on 4 outpatient services for a total of almost 30,000 consecutive patients patch tested from 1997 to 2021. This is the region where also cities like Verona and Venice are, so that I'm sure many of you may know. And the procedural patch test implies an application of a patch on a patient back and removal and reading at 48, 72, and 96 hours. And what has been used in this study was the Triveneto series, which is slightly different from the European one. As I said before, in America also, the series is slightly different. That includes different haptens. But these 22 haptens were consistently included in our study over the course of 25 years. So, descriptive findings. So we see quite a lot of variation in the number of tests performed, the number of positive results by research center and over the year. And here you can see the difference by center, with Trieste having lower positivity compared to Pordenone. And this is the trend over time. We can see like heterogeneity and decrease, especially after year 2002. And this table display descriptive results. So you have a column with the number of tests performed by explanatory variable, the number of positive tests, and then univariable and multivariable logistic regression analysis. The logistic regression, the multiple logistic regression analysis was adjusted for age, sex, center, body area, leg basically, and occupation. And as we can see, apart from heterogeneity by center, male sex, increasing age, especially after 60 years of age, and leg dermatitis increase the risk of sensitization. In the same model, displaying also the impact of occupation, we found an interesting association with house painting, like quite high risk despite wide confidence interval. So, descriptive finding, we find 1.64 prevalence, which is higher in males, and variability by research center. Median age of patient were tested were 49 years. The body area most affected were the hands, although sensitization was higher in legs. So this is an overview of a large study conducted in Europe and North America, assessing the prevalence and using different formulation at patch test. And as we can see, when the same formulation was used as we did, so lanolin alcohol 30%, the numbers are almost the same. Whereas when Amercol was used, the prevalence increased quite substantially. So prevalence we found overlapped with other studies. We found a decreased sensitization over time, consistent with a recent North American study, a large study on more than 26,000 patients. Variable prevalence in the open literature likely reflects the formulation employed, and the suspected higher prevalence of false positive in patient tested with Amercol is probably due to irritative effect of the mineral oil component of this preparation. And variability by research center endorse the ongoing debate on the clinical relevance of lanolin as an allergen and the respective patch test. Risk factor, we found male sex, age, after 30 years, especially after 60 years of age, leg dermatitis and house painting occupation increasing the risk of sensitization. In order to disentangle more the relationship, we fitted the same model as before, but including an interaction between leg, dermatitis, and age. As we can see, increasing age, the effect of age was stronger in patients affected by leg dermatitis, and house painter risk factor was confirmed, although only limited to women, and the number, as you can see, is only 3. So, basically, we found an association between leg dermatitis in patients older than 48. These people are likely to suffer from leg condition like stasis dermatitis that pose an indication for use of lanolin personal care product that might confound the association we found. Then the relationship between occupation and lanolin sensitization may be explained by, again, use of lanolin-containing skincare products, also used in workers to protect when in their activity. But again, we shall not exclude that this worker may be exposed to lanolin-containing varnishes. So that's the paper that we recently published, and that's the team that I work with, so the Northeast Research Center for Contact Dermatitis. Sorry for...
Thank you. I wish we had more time, but we need to move on. Thanks very much, Dr. Lucas. Let's move on to William. William Lugard from the University of Oxford, UK, the role of community health workers in meeting contraceptive needs. So welcome.
Thank you very much. I'm William Lugard. I'm a senior researcher in the Department of Social Policy and Intervention, and I'm presenting here on behalf of a series of co-authors across the Accelerate Hub and the APHRC in Kenya. Over the last decade, Kenya has experienced the youth bulge. Adolescent girls and young women of reproductive age represent 10% of the total population. And although unmet need for contraception has declined since 2003, the rate has remained stable now in the latest statistics since 2014 at around 34%. Similarly, the prevalence of adolescent pregnancy is at 15%, which is the same as it was in 2014 too. Adolescent pregnancy is associated with higher rates of stillbirth, miscarriage, unsafe abortions, and as well as school dropout. And so new strategies really are needed to accelerate declines in these outcomes further as we approach the Sustainable Development Goals. So kind of knowledge, so national surveys consistently show that knowledge of contraceptive use amongst adolescent girls and young women is high. Report statistics of around 98% in the last 4 national surveys. However, there are important supply and demand side determinants of their use, including inadequate staffing of healthcare facilities, discrimination and hostile attitudes to adolescent girls and young women, conservative community norms, perceived judgment, and partner and peer influences. In Kenya, there are over 86,000 community-based health workers who deliver health education, referrals, and health promotion nationally, which includes discussion of family planning and adolescent reproductive health. Qualitative studies show and highlight how these community health volunteers, as they are in Kenya, are able to overcome community norms that challenge contraceptive use in adolescents and have a good rapport with adolescents. However, there's really still limited quantitative evidence of how effective this service is for improving adolescent sexual and reproductive health. So our research aim was to evaluate if household visits from community health volunteers were effective for connecting adolescent girls and young women to health facilities, improving use of modern contraception, and reducing unmet need for contraception. So the research was partially informed by the health belief model, where we expect that the population has a high knowledge of contraceptives, but regular cues to action from community health workers help to address kind of perceived barriers and increase the likelihood of healthy behaviors, which in this case include visit to health facility and then ultimately use and met need for contraception. So what data did we use for this? We used the 3-wave PMA performance monitoring for action data, which is a longitudinal cohort study in Kenya. It's a uses a multi-stage cluster design in 11 out of the 47 counties. The sample size was 6,466 adolescent girls and young women, unique observations, but combined, that was 10,825 observations. There was large variation in the consistency of responses across the 3 waves. Our exposure is self-reported visit from a community health worker to talk to the participant about family planning. And our outcomes were first visit to healthcare facility, use of modern contraception, which are these forms are listed there. And then unmet need, which unmet need is different because it focuses in the sexually active group of adolescent girls and young women rather than use, which is amongst the whole population. So just as some descriptives, unweighted. Prevalence of household visits from community health volunteers in the last 12 months to talk to adolescents was 9%. Prevalence of health facility visits in the last 12 months amongst this group was 52%. Prevalence of modern contraceptive use was 29%, and the prevalence of unmet need was 25%. So for how did we estimate these effects? We used the random effects within between model that accounted for sampling and repeated observations with random intercepts. Our focus was on the within individual estimate because this by comparing individuals across time, we can control for unobserved time invariant factors. We weren't interested in the between group, partially because there was so much inconsistency in reporting across time that there might be selection bias. So in terms of what did we find, so household visits from a community health volunteer in the last 12 months were associated with 66% higher odds of a visit to the health facility in the last 12 months. We didn't find we found no evidence that these visits were associated with high use, and we found a sort of weak evidence that these visits were associated with a 32% reduction in unmet need for modern contraception amongst this group. What's interesting is that within the visits to a health facility were associated with with weak evidence, kind of 23% increase in use of modern contraception. But there was no interaction between a household visit from a community health volunteer and visit to a health facility. So I think kind of these slides, in terms of kind of summarizing the main findings, I think so. Community health volunteer visits to adolescent girls and young women in Kenya remain low at 9%. However, there is evidence that these visits are associated with higher probability of visiting a healthcare facility, which highlights the importance of these community health workers and volunteers in adolescent health promotion. But there's weak evidence that health facility visits themselves are linked to contraceptive use. And that if there's weak evidence that health facility visits are linked to contraceptive use, and that CHV visits are also associated with lower unmet need for contraception, does kind of highlight areas for improvement. And I suppose there's a recent systematic review came out of all capacity building materials for community health volunteers, and adolescents was a group that there were no capacity building training materials for. But to come back to kind of that first point that's highlighted at the top of the slide, there really needs to be a clearer consensus, and I can't find this in the literature, around what the goal of and the outcome, how we measure community health volunteers in terms of what outcome they're expected to achieve. So in terms of, particularly in relation to adolescent health promotion, is it their role to connect adolescents to the health service, which we see in those results that they are connecting adolescents to those health services? And is it the health services then role to take on whether or not providing addressing those supply side determinants of contraceptive use? So kind of just some broader thinking. So in terms of the strengths, three-wave data, rigorous statistical methods, limitations, self-reported variables, and unfortunately inconsistent response patterns across waves. But I think some interesting findings and important kind of guidance for next steps. So thanks to everyone that's been involved in this work and the teams across these institutions.
Thank you very much. Thank you very much, Lucas. Thank you for keeping time. We move on to our last presenter, Shrut Mathi from Center for International Health in University of Otago in New Zealand, talking to us on strengthening the reporting of observational studies in epidemiology. Welcome.
Good morning, everyone. I'm Shruti Murthy, a postdoctoral fellow from the Center for International Health, University of Otago, New Zealand, presenting on strengthening the reporting of observational studies in epidemiology, enhanced prevalence and incidence criteria, or STROBE-EPIC. Our project is funded by the Bill and Melinda Gates Foundation through the Typhoid Vaccine Acceleration Consortium. To begin with, some background which leads to the motivation for this project. It is recognized that there is a lack of transparent and accurate reporting in published health research literature, which compromises the reliability and comparability of published research. Enhancing the quality and transparency of health research, or Equator Network, is an international initiative to promote the standardization in research reporting. Strengthening the reporting of observational studies in epidemiology, or STROBE guidance, sits within the Equator guideline landscape to improve the reporting of cohort, case control, and cross-sectional studies. So how does this connect to what we are doing? Prevalence and incidence have numerous applications in epidemiology. We identified systematic reporting quality issues that highlighted the incomplete or inadequate reporting of observational studies of prevalence and incidence that are not covered under STROBE or its extensions currently. Our proposed extension and its scope resonated with the wider community working in prevalence and incidence, who acknowledged the lack of attention in this area and supported the STROBE EPIC initiative. We thus aim to develop the STROBE extension, Enhanced Prevalence and Incidence Criteria, or STROBE EPIC, to enhance the reporting quality of observational studies describing prevalence or incidence. To summarize the methods, we followed the guidance for developers of health research reporting guidelines published by Moher et al. That is shown in the snapshot, and the citation is provided to the lower right corner of the slide. We used established consensus development methods to elicit expert opinion, to generate, revise, and reach consensus on the proposed checklist items. We also used a piloting exercise to critically assess if the checklist was clear, concise, complete, and free of errors. The slide here shows the activities and timeline of the development of our checklist. First, we conducted 5 systematic reviews from 2018 through 2021, during the course of which we identified systematic reporting problems in prevalence and incidence studies. Next, we generated a preliminary checklist from October through November 2022, responding to the issues from our reviews. We then conducted the first Delphi survey from November through December 2022, with diverse international experts in typhoid and other salmonellosis, including clinicians, epidemiologists, modelers, and burden of disease researchers. Next, we convened a face-to-face consensus meeting in Cape Town on 6 December 2022 with these diverse international experts, where we confirmed the need for STROBE EPIC and revised the preliminary checklist. After the meeting, we conducted the second Delphi survey from March through June 2023, extending to experts on other infectious diseases. Next, we conducted the third Delphi survey from July through November 2023, extending the survey to experts in non-communicable diseases and injuries. This was followed by a piloting exercise from November 2023 through January 2024 among the Delphi participants, postgraduate researchers, research team, their networks, and collaborators. We then finalized the checklist in February 2024. To give you an overview of the finalized STROBE EPIC statement, STROBE EPIC provides guidance in the form of a 47-item checklist and an accompanying explanation and elaboration statement. These recommendations are in addition to and not a replacement of the STROBE guidance. STROBE EPIC will be applicable to observational studies in epidemiology describing prevalence or incidence data of disease, complications, or deaths of communicable, non-communicable diseases and injuries. The checklist will be applicable to all parts of manuscripts, including the supplementary material. The checklist consists of essential items that we recommend be reported in all observational studies of prevalence or incidence, and then items to be reported where applicable. While the complete checklist consists of 47 items, I have insufficient time to cover all these items. So in the interest of time, I will give you a flavor of our checklist by illustrating it with one item. So I provide here an example of a STROBE EPIC checklist item, number 6.2. This item is for eligibility and case definition. The rationale for inclusion of this item in our checklist includes the following reporting issues we found during our systematic reviews. So inadequate description of eligibility criteria of participants, unclear or inadequate descriptions of definitions of cases and classes of cases, or using inappropriate diagnostic criteria, and ambiguity in how complications were attributed to a case and assessed, including the temporality, which is the sequence of disease and complication, and the time window for attribution. Therefore, in item 6.2, we provide guidance on the eligibility of participants and case definition. It has 3 items, 6.2a, b, and c. In 6.2a, we recommend that authors provide diagnostic criteria in sufficient detail to be replicable. We provide some examples to help authors get an idea of what we mean. For example, the Diagnostic and Statistical Manual of Mental Disorder Classification or Self-Reported Cough Duration. Next, in 6.2b is for case definition, where we recommend that authors provide definitions for classes of cases and comorbidities in terms of person, place, and time, and others as relevant. Examples for this item include suspected, probable, or confirmed leptospirosis, diastolic blood pressure above an accepted threshold of millimeter mercury. There are several examples in the checklist, but I have listed only 2 here per item in the interest of time. In 6.2c, which is to be used when authors report complications, and it has 2 sub-items. In 6.2c1, we recommend that authors provide definitions for complications. In 6.2c2, we recommend authors to describe the method with references where applicable for attributing a complication or death to a cause, including temporality and the time window for attribution. To conclude, we developed Strobe Epic to improve the reporting of prevalence or incidence data. We anticipate that this will be a valuable tool for authors, modelers, burden of disease researchers, peer reviewers, journal editors, and finally health policy decision makers. The checklist will be available for download, use, piloting, and feedback once the manuscript is available as a preprint in November 2024 and in subsequent publication in 2025. You can also find updates on Strobe Epic on Equator Network website and the quarterly newsletter in 2025. I have provided the link here. Please feel free to reach out to us at this email address provided here to know more. To end, on that note, I would like to acknowledge and thank the entire Strobe Epic team, including the co-authors, the executive team at the University of Otago, highlighted in yellow, and the Delphi and piloting participants, and the Typhoid Vaccine Acceleration Consortium, or TIVAC, which is funded by the Bill and Melinda Gates Foundation. Thank you.
Thank you very much, Shruti, for good presentation and for keeping time. Now it's time for us to have the Q&A session. We have some time for that. So please, if there are questions to any of the presenters, let's walk to the microphone there and then ask. We'll take a session, we'll take a few questions and then get answers. If there are more questions, then we'll continue. So feel free to ask any question to any of the presenters who are in front here.
Thank you for all the people who presented really interesting presentations. I'm curious, my question's for William. I'm curious about your research. I don't know, I might have missed that bit, but how did you involve local communities and researchers and the community health workers when you were designing the study or the interpretation of the research finding, especially since it's set in Kenya?
Yeah, great question. So the work was carried out with local researchers. So Berlin is first co-author. He's not here today. The APHRC is the African Population Health and Research Center in Kenya, and the research was kind of carried out in collaboration with them. The data was collected, so it's a collaboration. The data was led by Johns Hopkins University, the data collection, and is publicly available. In terms of actual participation, we've had informal discussions with community health volunteers. Community health volunteers in some regions of, in one region of Kenya, but not with adolescents themselves.
Yeah, go ahead, you can ask the question. If there are other people who want to ask questions, please come to the microphone in the middle there. Okay. Thank you.
Thank you, everyone. Thank you for your talks. My question is to Amandi. I just want to know more about the strengths-based approaches that you've mentioned. I don't know, maybe I missed it in your talk in terms of the regression approaches. Thank you.
We can go to the next question.
Yes, my name is Halvor Sommerfeld from the University of Bergen. I have a question to the last speaker. Thank you for a very nice presentation. This tries to improve on prevalence and incidence approaches to measure it properly, right? And it seems that you're restricted to observational studies. We do have consort guidelines. Are you thinking that those are good enough for those purposes, or would some of these criteria apply also to RCTs?
Thank you. Go ahead. The other question. We'll take a few more questions and then we'll get some answers. Thank you.
Hi everyone, great presentation. My question goes to the first speaker around population size estimates for sex workers. And I think there's a big conversation right now around targeting for prevention of HIV or targeting for different types of social ills, so as to say. I guess, how do you see us using population size estimates to destigmatize and not to kind of fall into the trap of targeting key populations, creating differences that we're already struggling with in the public health HIV area to kind of walk away from, that tend to sometimes do more harm than good?
Thank you. Any more questions? Maybe let me add one or two questions. You also want to add? Okay, let me add. Lanolin. The study on lanolin and patch testing, yeah. You on your results, you showed that atopic dermatitis was less likely to have positive lanolin patch tests. The normal assumption is atopic dermatitis patients normally have a highly sensitive skin, and I would naturally expect that they would react much more. Maybe you can comment on that. And then the second question on to the sex work, Nanina, you were estimating over 170,000 women to be potentially sex workers. Was there any age differentiation in this analysis? So maybe we give our speakers chance, but before then, let me get my co-chair to ask.
One question for the president from Australia. In such young population, did you look at the cause of the CKD and what can be done because of the high cost of managing end-stage kidney problems? Thank you.
All right, I'll answer the first question, which is regarding the strengths-based reporting. So, as I mentioned in the presentation, one of the ways of strengths-based reporting is to identify the modifiable risk factors. So obesity is a modifiable risk factor, and that actually presents us an opportunity to intervene from an earlier stage. And through this, we are able to provide this data back to community so that they're able to identify these risk factors. The other way is that we've got an advisory committee which includes Indigenous stakeholders who are community leaders, patients, and also researchers. And we're going to be working with them to provide this to identify the best ways in which we can provide this data back to community so that we can create health promotion that is culturally safe. Sorry, I missed the first part of your question. The cost of CKD? The cause? Okay, so one of the main risk factors that we've identified is obesity, which, as I mentioned, is a modifiable risk factor. So, and the other risk factors that we've currently identified are rural and remote living. But this is an initial analysis, and we do intend to undertake further analysis in the future that looks at more of a life course approach.
Regarding your question, I mean, it's a good question. I don't know how to answer, to be honest. I can only say that the model didn't fit, the variable didn't fit into the multivariable model, so that was excluded at the end. And also, that may have something to do with the enhanced risk of sensitization in males, because normally women are more likely to be sensitized and have atopic dermatitis. In this case, male were more likely to experience sensitization to allergy. So the debate is still ongoing on this upturn. One of the things that may be done at global level maybe is to standardize the upturn to be used in the series. So in Europe, we use 30% alcohol. In North America, they used to use 30% alcohol, and now they shifted in the last 10, 15 years to Amercol. I don't know exactly why. In Europe, experts believe that Amercol overestimates the positivity. In America, they think that 30% alcohol underestimates positivity. So there is a lack of consensus. I'm not sure whether I answered your question, but I tried.
Thank you for your question. So regarding whether, I think I'll just combine both the parts. Yes, there are the consort guidelines for the trials, but our recommendations will be applicable only to the observational studies. It's not because the way the reporting of prevalence or incidence in randomized control trials or intervention studies are up to the mark, but it's only because of the way we approached it. So to tell you in a moment how we did it, our systematic reviews was mainly on studies of observational studies of prevalence and incidence. And in one of the systematic reviews in meta-analysis, we also included vaccine trials, the control arms of vaccine trials for looking at the incidence of vaccine preventable disease. And we did find a lot of issues in those trials as well. However, because all the 5 systematic reviews are on observational studies, we thought just because of the few trials we included and we found issues, it would not be correct to make a blanket statement for the trials as well. And therefore, the scope of this would be applicable only to the observational studies at present. However, in future, because guideline or extension landscape is evolving, we think maybe if we are going to do any systematic reviews which particularly focus on intervention studies, then maybe if the list of reporting issues are significant enough to warrant a guideline or an extension, maybe not. Like just the talk I attended yesterday on the target trial and how just developing an extension for a tight issue that we find is not appropriate. So currently we are restricting it only to the observational studies. I hope that answers your question. Thank you.
Should I answer?
You have an answer? You have a question?
Yeah. To the first question, if I understood it correctly, it was about whether or not it could be that deriving these population size estimates actually could lead to an increased stigmatization. And of course, that is completely not what we want to achieve with our study. I'm probably the wrong person to give a very good answer to that question, but because I'm coming more from the data science modeling side. But maybe what I can say is that in their latest strategy, UNAIDS focuses very much on ending inequalities in order to end AIDS, and with a specific focus on key populations. And so our reasoning behind this was kind of, okay, we have these estimates for key populations in South Africa, but they are based on very simplifying assumptions with a lot of uncertainty. And so what we actually want to achieve is improving knowledge on like key populations and specifically on sex workers. So kind of being able to know where most sex workers are and seeing our resources really allocated where we assume that most sex workers are might actually help to improve interventions. And for the age differences, I actually got a similar question by a very nice colleague of mine when I presented my talk to her as a test run. And so I'm actually trying to implement that at the moment. So we know that there are sub-districts where you do have, for example, rather an older population compared to rather a younger one, and this, of course, could also explain some of the differences. Thank you.
Thank you, thank you. And do we have any more questions from the team? Any more questions? I had one question from the previous presenter, Thiago. My question was, how do you measure empowerment? I know I was raised by my grandmother who never had any income, but she sent everybody to school. I still think she was an empowered person. Is empowerment equal to income, or how do you measure empowerment? So maybe you can respond to that. And then I also had a quick question to the colleague who was presenting on less one. You said the instrument did not make any prediction on its own, but you needed to add other variables. So how can we use that instrument if we don't have other variables? Can we still use it? So just yeah, you can touch on those.
Thank you for the question. That's a big question. There's a lot of research in the literature, some of the colleagues here, about how we actually measure empowerment in general. I would say that what we try to do here is not to measure women's empowerment, but very specifically women's economic empowerment, which is one aspect of all the other aspects that can fall within women's empowerment. So even the example that you're giving, some women can have be extremely empowered in specific aspects while still lacking empowerment in other parts. And of course, given the SDG 5, what we're trying to do is to reduce inequalities and make sure that women are empowered in all of those. For this work, what we did previously was a selection of looking at different, so we have social empowerment, so we can have something related to education. But for this, it was based a lot on the challenges faced with within the wash sector, where that lack of empowerment, specifically related to not being able to pay themselves for example, construction of a latrine, etc., or being the owners of the house or the land, but not the ones in control, actually changes a lot the way that they can actually implement those wash infrastructure. So we decided to focus on that specific aspect, not on the general broad sense of empowerment.
Thank you very much for the question. In this particular study, as I said, the tool didn't fare as well as the traditional cutoff of 10. In the previous study that we did, it actually fared pretty well. And again, what we try to do is try and keep it at the way that it is already used without making too many modifications. And in the study, as I said before, it fared pretty well. In this particular study, unfortunately, at the traditional cutoff of 10, it didn't, but it was also a very targeted population. So the previous study was all admissions, medical and surgical as a whole, which did tell us that we could use it across the organization or in the setting, but when we tried to focus it more on a medical-only population, again, at the cutoff of 10, it didn't work as well, but when we changed the cutoff to 12, then it did actually work. So currently we have implemented it in using it across all admissions of 10, but changed it for medical admissions to 12. And that is the way that we've currently implemented this, just to use it as a trial. And then what we're actually now going to be doing is a prospective study where we actually want to look at how accurate is this actually in predicting readmission risk and coming back to hospital.
Thank you. Any more questions to our current panel? Any more questions? Yes. If you have a question, is that a hand up? At the back there? You have a question? If we don't have any more questions, then we can gladly really put our hands together, our big hands, for our esteemed panel, the current one and the past panel, and also for ourselves for being present and for asking questions. Let's clap for ourselves. Thank you very much. My co-chair may have to close the meeting. Thank you.
Well, thank you very much for coming, and we hope we can continue to increase knowledge. And as we draw the WC to an end, we hope you all come to the next one in Colombia. Thank you very much. Presenters, let's take some group photograph for memories. Thank you. Please come.